So this video we're still on test and measures number 2, and we are now going to look at passive accessory intervertebral motion. Okay, we just finished looking at passive physiological intervertebral motion, in which we took the patient through passive range of motion while we were palpating either articular pillars or palpating between spinous processes to get an idea in general of how the different segmental levels are moving. Okay, so through the passive physiological intervertebral motion, we may have become aware of some areas of the cervical spine or of certain segments that might need more closer evaluation. So that's where the passive accessory tests come in. Okay, so now we're going to go back to some of those levels or some levels in question, and we're going to very specifically do a spring test at the end range of the facet joint motion, depending on what motion we're testing and which direction we're testing, to get a sense of whether the end feel is a nice springy end feel, as end feels should be, or whether there's a hard end feel, which would indicate that there might be a decrease in accessory motion, or if there's too much. Okay, you don't want what we call an empty end feel, where you feel like, whoa, that's a lot of motion going on there. So that would be something, an indication for not doing any mobilizations at that level. Okay, so we're going to go back to some things that, one that we looked at with passive physiological motion. So it's going to look really similar, where I'm going to be on the occiput, on that suboccipital ridge, my fingers like this. Okay, I am going to create a little bit of passive OA forward bending, but then at that end range, okay, remember what happens with this. It is an anterior roll and a posterior slide of that convex occipital condyle on each side. Okay, so what I'm really assessing as I bring him into his end range of forward bending, and if I provide a little spring at that end range, which on him on the right seems to be, at least he's telling me it's tender. Okay, I also want him, like your patient, to tell you whether something feels tender, or oh, that provokes my symptoms that I came to you with, or oh, that feels good, keep doing that. So what I'm doing then at that end range is I'm assessing that posterior slide at that end range of forward bending. I'm going to do it on both sides. If I want to really localize it to the right OA joint, I could bring him into some right rotation, about 30 degrees of rotation first, and then do this little bit of forward bending with the spring test at the end. He does not like it on the right hand side. Now these boys have been on their laptop computers playing games for
a week.
1 week, lots of weeks of quarantine. So I've been kind of yelling at them about their posture a little bit. So this doesn't surprise me with the forward head posture positioning that we have going on with the laptops, that they have been in a lot of OA extension, which puts these muscles back here in a shortened, tightened position. So it doesn't surprise me that you feel that.
Yeah.
Now later when we get to treatment, I can let you be the patient and I can show you some things that you can do to help with that.
Amazing. I'm looking forward to it.
Yeah. Okay, so that is for bilateral and unilateral OA forward bending. Actually, sorry, yeah, that was forward bending. Now for backward bending, it all looks the same, so let your head relax. Sometimes your patients don't want to relax their head in your hand. I just tell them to let the whole weight of your head just relax in my hand until they relax. So now we're going to do backward bending, which is a posterior roll and an anterior slide. Okay. There is also an accompanying video where I do all of these accessory tests on my plastic spine. Okay, so maybe you watched it before this particular video. If you didn't, make sure you watch it after. Okay, but again, remember, it is a posterior roll and an anterior slide. That is what happens at that articular surface. So I'm going to bring him into some OA backward bending, and I'm going to spring test that anterior slide. So that spring test is right there at the end range, quick little spring to assess whether it is springy or a hard end feel or feels like too much motion. You're going to start to get a sense the more hands you put on patients, or I should say the more patients that you put your hands on, what normal feels like and what springy end feels feel like and what doesn't. So I could also, to be more specific and to localize to the right OA joint, bring him into some right rotation, OA backward bending, spring. So can you see that through the video? See that spring at the end range. Are you paying attention, son? Okay. So that is for OA backward bending. All right, turn over on your stomach. What you guys don't know is that on our first outtake of this video, we made it almost through to the end, and then these guys went bananas, and none of us could stop laughing.
You were laughing harder than us.
I may post it just for comic relief, and just for some, you know, sometimes it's good to hear things again.
$10 each.
Wait, we're not going to start. All right, put your head here. So now we're going to do central PAs. Put your arms down by your side. Since I'm not going into the thoracic spine, I'm going to not make him take his shirt off because that's going to stay here. As long as it stays below his T1-2 level, we're going to be good. Okay, so now what we're going to do, and I think I'm going to start adding, using plastic spine model.
Put it on my back. Feels weird.
My thumbs are going to be in a V position. So see 1, 2, 3, 4, 5, 6. Let's do 6, 7. So if I want to assess this central PA of C6 on C7, I'm going to have my thumbs in a V. Okay, I'm going to be directly over the patient, perpendicular to the spinal curvature at that level, and I am going to impart a spring test from a posterior to an anterior direction. Okay, so I'm here, spring test. Okay, so really what I'm looking at is extension of C6 on C7. You guys see that? Okay, now, before I actually show you on him, if I want to do it unilaterally, okay, I'm on this facet of C6. Okay, so this is the superior facet. The inferior facet is actually the superior facet of C7. But if I come here and I do this unilaterally, if the patient's neck is wide enough and you can still make a V, you can. This is what set them off in the last video, guys. This is not happening. I said Ethan had a little neck, and they thought that was the funniest thing ever. I'm not sure why. Is it an insult?
Yes.
It is? Okay. I'd rather not have a big giant neck or a neck that runs right into your head. So I just wouldn't. All right, let's not go there. Stop. They keep calling me boomer. I don't get it.
Yeah, it's funny.
Stop. We are not doing this again. This is what happened. They went.
Spine feels weird.
Do the thing.
They went off the rails.
As fast as you can.
All right, be
Do the
quiet.
thing.
Stop. So here's what we're gonna do. In all seriousness, if I do a unilateral PA on the right side, what this creates, if you can see this, is a down glide of C6 on C7. Okay. So we know that down glide creates extension. We also know that if it's unilateral, down glide on the left, that there's going to be an equal up glide on the right side. So it's going to create side bending, okay, and rotation to the ipsilateral side. Okay, so that is a central PA and a UPA.
Thank God.
Okay, put your head back down. Okay, so here's what it looks like on my patient here. Okay. Okay, about C6, C7. Okay, I sink through the tissues. I appreciate the bone of the spinous process. Quick spring test. Looking for springy end feel. I'm also asking him, if I were using this as a screening test for a patient's neck, I would say, does this provoke pain? Because these are great provocation tests to help identify levels of dysfunction. Or if he had pain, I would ask him, well, does this force here make your pain feel better, or does it make it feel worse, or does it not have any effect? Okay, and then I'll come out here and I'll do my UPA, same joint level. I'm going to do one thumb over the other, so really the one that's pushing is this one. The one that's in contact with the joint, we call that a dummy thumb, because the force is coming from the one on top. And yes, haha, I said dummy. And there we're doing a UPA. Now, one thing that I could do to change
Oh. Beat him with the spine?
I just hit him with the spine. I did.
Alright, the spine hurts.
It does not hurt.
When you push on it, it does.
Okay, I won't push on it. All right. So now what I'm going to do, don't make me start this over. Instead of doing the straight UPA and creating ipsilateral rotation and side bending, I am going to angulate my finger this way, okay? And instead of pushing straight PA, now it's going to be still a posterior to anterior, but it's going to be up at a 45-degree angle in the plane of the facet joint, okay? So I'm going to just, instead of having a flat thumb, I'm going to turn it this way. And I'm going to angulate myself to be a little bit more than over the patient so that I can have my direction of force. It's a little hard to do, so just make sure that when you're pushing with your mobilizing thumb that you're in this direction. Okay? Yeah. Okay, so that is going to create an up glide of that superior facet on the inferior facet, which we know then is going to create contralateral side bending and rotation. Okay? That's what happens when you do an up glide of the superior on the inferior facet on the left side. You're going to create right side bending and rotation. So this is what it looks like. So your direction of force is this way. Okay? So it's a subtle change in direction. Okay? So instead of the straight UPA, I'm going to angulate my thumb this way. And now my force is, can you see the direction that I'm mobilizing? It may not be great for you to be straight on from above. Maybe from over here. So it's this way, okay? As if I am mobilizing up towards his eye, okay? Assessing the end feel and also asking about provocation of symptoms. That is doing an up glide in a prone position. Now we're going to do it in a supine position. So turn over on your back. Okay. All right.
Oh, it's bright out here.
Mm-hmm. Now what we're going to do...
Oh boy, I get to hold the spine like a saxophone.
Ethan, stop. Okay. Now, to do an up glide or to assess accessory motion for an up glide in a supine position, you can still see, you see these angulation of the facets up toward his eye at 45 degrees. I'm going to have the radial border of my index finger at my MCP on targeted facet level. Okay, so if that's 1, 2, 3, 4, 5, so 5 on 6. If I do an up glide of C5 on C6, I am going to be creating left rotation that way. Okay, so what it looks like with a patient. So I'm going to stick with left rotation. I'm going to use my left hand under his occiput just to cradle it. Okay. Right MCP joint, about C5 on C6. Basically, I'm going back to those levels that from the passive physiological motion that were in question. So I'm going to come back, be quiet. Okay. And I am going to have my MCP on that level. And I'm going to sink through the tissues. I'm taking up the soft tissue slack until I feel that MCP on the articular pillar. And then I'm going to provide a force up at 45-degree angle towards his eye. Okay? I'm assisting with the motion a little bit with my left hand that's cradling his occiput. So you're going to see a little bit of rotation that's happening, okay? But not mass amount of rotation that I was doing at the passive physiological motion, because I'm not really assessing his passive range of motion right now, okay? I do turn his head a little bit naturally because that happens when I perform an up glide at this segmental level. But here what I'm trying to appreciate is what I'm feeling under this MCP joint. What does that end range of that facet glide feel like when I get here, and then do a quick little spring test. Okay? So I hope that makes sense. We're going to practice all of these when we get back to school at some point. Okay, so that is an up glide. Well, what about down glides? Okay, so for a down glide, get your spine back. Okay, instead of cradling the occiput and then rotating this way up towards the opposite eye, I'm same spot, still using this MCP, but now my force is going to be on a diagonal towards his opposite hip, or ASIS. So the up glide was this way. The down glide is this way, that way, in line with the facet joint. So when I do that, you're going to see a little bit of ipsilateral side bending, because that's what happens with ipsilateral side bending. There's a down glide on the ipsilateral side. Also happens to be an up glide on the opposite side, but I'm not monitoring that with my left hand. Okay, so on my patient, I can be standing or sitting. Right now, because this table's too low for me because it's not adjustable, okay, it's easier for me to stay sitting, okay, because I want my motion to be in line with my forearm, and it's in sitting, I'm level. If I'm up here, I have to squat way down in order to do it, and that's just harder on me. Okay, so my left hand is supporting his occiput. I have my MCP ready here, my right index finger. Okay, I'm going to come to about that C5-6 level. Okay, does it really matter? No, I'm going to be assessing all of the joint levels, and I'm going to treat those that have hard end feels. Okay, so it doesn't really matter. Like, oh no, what if I'm not on C5-6? What if I'm on 4-5? Doesn't matter. You treat what you find. Okay, so all I'm going to do, I have my MCP on the articular pillars. I'm sinking through the tissues. And then when I feel like I'm up against the bony part of the articular pillar, I'm going to impart a force in this direction, and then I'm going to spring test that end range. So you can see the vertex of his head does move, okay, relative to his chin. So come up so you can see that, because I'm going to show you something that's going to be a little different in a minute. You see how his chin stays where it is, but the vertex of his head moves to the right. So I'm creating a side bend, and I'm springing that joint at the end range. And I can move all the way up and down his cervical spine. Okay, and then I can do the other side. So I'm going to switch. Okay, and now we're going to test down glides on the left side. So you can see a little bit of side bending.
A little tender.
That one was a little tender. Good information. So
Just only a little bit.
yeah, so I might assess it. That one to me doesn't feel quite as springy as some of the other ones. Okay, so I might come back and treat it, but we're going, and the joint mobilizations that we'll do later look exactly the same. So we'll come back and we will mobilize that area. Okay, now the next one and the last mobilization is going to be a lateral shear. Okay, so remember with shearing, we talked about that. We talk a lot about up glides and down glides at the facet joints, but we also talked about how with side bending and with flexion and extension that those vertebral bodies need to be able to shear over the intervening intervertebral disc. Okay, so instead of focusing on the articular pillars at the moment, or focusing on what we're feeling at the facet joints, okay, we're going to do an accessory test where we assess the shear of vertebral bodies. So now you're going to scoot back. Okay, I'm going to just a little bit, not far, just enough so that I can have full control of his head. His head is against my belly. This is fine, and you're relaxed. Again, this table's too low for me, so I'm kind of squatting. But what I want, you can relax here. Oh, hi Stella. Is for my feet to be side by side like this, because the shearing motion is going to be from me doing a weight shift. Does So can you see what I'm doing? Okay, so I'm shifting side to side. Now, my contacts,
Oh
I'm
man.
not gonna hit you with the spine unless you guys lose it again.
Dance.
Don't do it. We are so close to the end
Gonna hit us and then we're
of
gonna
this
lose
one.
it.
There's a lot more to come. I'm gonna have the pads of my fingers, probably my index and my middle finger, along the articular pillar like this. Okay. So if I wanted to shear, so this is 2, 3, 4, 5. Let's say 5 on 6. I'm gonna be on the facet of C5. Okay, on that part of the pillar on both sides. Okay. And then we're going to create a shearing motion. If I want to shear to the left, I am going to shift my body weight, and with these 2 fingers on C5, I'm going to create a lateral shearing force from the right to the left. Okay, so shearing that way. And I can do this up and down the spine. And then I can do it from left to right. Okay, so these are just resting here. Now my force is coming from my hand contacts on C5 on the right as I shift my weight towards the right. So I'm creating a right shear of C5 on C6. And then when I get to the end, I'm gonna spring test and just see, quick little impulse. And I may check it a couple of times, okay? Looking for nice springy end feels. Okay?
Sharp bit on the pelvis there.
So the, with the down glides, you guys noticed that it looked more like a side bending, okay? This one, okay, is not gonna look like a side bending. In this case, the vertex of his head and his chin are gonna travel together, okay? So it looks like this,
That's tender.
yeah, that way, okay? And this segment, and I spring test it, it's tender to him and not quite as springy as some of the
Alright,
other
that
levels.
one's good.
And then I can check to the left, okay? Moving my body, you can see the vertex of his head is moving with his chin. So we're creating a lateral shear, okay? These are vertebral body shears. And spring testing at the end, we will likely want to then come back and treat any hard end feels that we find with joint mobilizations. And the mobilizations are gonna look just like these. Okay. That concludes passive accessory intervertebral motion. We made it. Oh,
Yes!
you guys have no idea what the last take looked like unless I post it for you. Anyway, we're done.